Our next speaker is Peter Gow, who is a rheumatologist. And I'll hobble off.
Right.
Just click forward. I think I'll cut to the chase in order to allow more time for discussions. So what I want to focus on is what is going to get us from pilotitis, business as usual, into the brave new world. I really enjoyed Kate's talk. It had the wow factor that I was introduced to when I first started being part of implementation teams at Middlemore in the mid-1990s, and you see your first digital radiology image on the screen after having spent hours trying to find the x-rays, and you think, if this is what e-health's all about, I've got to have something. Now, this slide, the relevance of this slide is that this was at a conference on metabolic disease, diabetes, and ways of overcoming it, and this is given by Chris Cunningham, who's a lecturer at Massey University, and this is the lecture that should be shared with every doctor in New Zealand, particularly in the north and the east coast and South Auckland and Waikato and a whole range of other people. But many people didn't find time to go there. Those that did, the wow factor here was that Peter Snell was the guest speaker. And so somehow we've got to create an air of excitement around changing to e-health so that people don't just say, well, that looks like far too much work, or is it worth the money, or are they going to pay me anything extra? And I think that what I enjoyed about Kate's talk, and I think those people who go to the telehealth meeting tomorrow will get that sense of excitement about why we should be moving into that area. Now, on the basis of that excitement, we can then look at getting the bread and butter stuff in place first, because it's always easy to attract people to the wow. It's how do you get the basic stuff? And so one of my roles is as chairman of the National Information Clinical Leadership Group, which sort of works in a co-design role with the community panel and the National Health IT Board, looking at ways by which people's health information can all be connected up so that we're getting a shared view of what that particular person wants and needs, and so they're not getting mixed and confusing messages. And in the 2 years, there has been quite significant progress on this, despite lack of money, which is one of the issues. For example, at our hospital assets and capital round, none of the IT projects got above the line until we did some special pleading. So some of you may not know, and this is the last slide, this is the National Health IT Board priority programs. The ones on the top left, e-medications is the really critical issue with respect to patient safety. And in the Otago region, probably the first place in New Zealand, if not in Australasia, they have an e-prescribing inpatient service which is now going from 48 beds to 148 beds. The independent evaluation showed that there were next to no e-prescribing errors or prescribing errors. So that's a huge advance. You'll see that in the national systems, it is a way of getting people, clinicians across the country, working with each other to say, well, look, if this is good for the whole country, we'll work together and we'll settle differences. A lot of the other programs are regional. I think that this was one of the masterstrokes of the National Health IT Board. They realised that clinicians in 20 DHBs plus all the primary care people are not going to agree to one program overnight. So if you break it up into regions, you have the chance to develop relationships and influence. And a number of these are integrated care initiatives. So instead of us talking about primary and secondary care, secondary care interfaces, what we're doing is we're working together with the patient at the centre. Now, one of the things to help the patient be at the centre is to develop health literacy programs, and the ministry is doing some very good work in that. And one of my hands-on roles is I'm part of the shared care plans for long-term conditions for patients with gout who often have a lot of comorbidities, and it's my interest and passion, very poorly treated in New Zealand. And it's very good to be part of the program and to be working out what works and what doesn't work in a hands-on experience. Thank you very much.